Good afternoon, good morning, and welcome everyone to today's webinar, Chaplain Case Study Research, Building a Foundation for Geriatrics and Long-Term Care. I'm Andrew Andresco, Project Coordinator for Transforming Chaplaincy, and we are delighted you could all join us. Some housekeeping instructions off the top. You are listening in using your computer speaker system by default and are muted. Should you have any technical questions regarding your audio or visual, please type those into the chat box located in the platform's dashboard. You will have the opportunity to submit text questions to our presenters at any time. You can put those into the questions box on the dashboard of GoToWebinar. We're going to have a Q&A session at the end and we hope to address them. I've also have some promotional slides at the end with our upcoming webinars. We've got two coming up, one next week and one the following week. While I have registration links there, I've also put in some QR codes. If your smartphone is handy, you can just take a picture of the QR code and that'll take you right to the registration page. And with that, I'd like to introduce Sarah McEvoy. She's a co-convener of Transforming Chaplaincy's Elder Care Research Network, along with one of our other hosts, Kathryn Lyndes. Sarah?
Thank you so much, Andy. I appreciate that. Well, welcome to our webinar on Chaplain Case Studies in Geriatrics and Long-Term Care. Before I introduce our presenters today, I thought I would just take a minute and quickly highlight a couple of the things that we're going to touch on. We will highlight some of the important work being done by chaplains in this area. We'll talk about the fact that there really aren't any shortage of cases, just a shortage of people willing and able to write them and have the confidence to push them to the next level of publication. We'll make a case for more case studies, especially in areas where there are gaps, which I think happens to be geriatrics and long-term care, so very excited about that. And finally, and perhaps most important, we are going to demystify the process and provide skills for both analyzing and writing case studies. So to help us do this, next slide, please. I'd like to introduce the group that we have here this afternoon. Of course, Andrew mentioned my name is Sarah McEvoy. I'm a retired nursing home administrator, a long-term care chaplain, and one of the co-conveners of the Elder Care Research Network for Transforming Chaplaincy. With me also is Kathryn Lyndes, co-convener of the Elder Care Research Network and assistant professor of social work and gerontology at St. Mary's College in Notre Dame, Indiana. And finally, we are both pleased, Kathy and I, to have our esteemed colleague, Jeanne Wirpsa, with us. Jeanne is the program director and clinical ethicist of Northwestern Memorial Hospital and a faculty member of the MacLean Center for Clinical Ethics at the University of Chicago. Jeanne is also the co-editor of the text Chaplains as Partners in Medical Decision-Making, Case Studies in Healthcare Chaplaincy. So Jeanne, we're just delighted to have you here with us sharing this presentation. Thank you very much.
Jeanne, you're muted.
Thank you, Sarah, for that warm welcome and introduction. Our outline for today's webinar is posted here. Again, I'm going to take a little bit of time trying to help us appreciate why case studies are an important contribution to chaplaincy research, look a little bit at how we might actually dive in the nuts and bolts of creating case studies, and then I'll turn it over to my colleagues to explore deeper in this specific area of elder care. What are the opportunities for writing and analyzing case studies? Next slide, please. As I start today, I want to actually acknowledge a colleague who's not with us today, and that is Kate Desjardins, who is a chaplain who mostly does pediatric chaplaincy now and is the leader of the Chaplaincy Research Network devoted to pediatric care. She and I, in the fall of last year for Spiritual Care Week, put together an hour-long webinar entirely devoted to helping our colleagues appreciate the resource of case studies for their own learning and to encourage folks to do research themselves using the case study methodologies. So some of these slides are adapted from Kate's and my creation from that webinar for today's presentation. Why do we want to encourage you to do case studies? Well, they are vital for building our field. They are, as you see on the right-hand corner of my slide at least, part of the hierarchy of evidence for research that we share with our colleagues, with our medical colleagues. And while they may not rise to the level of randomized control studies, for us, in our development of what we know about chaplaincy care, they are perhaps the most appropriate level to open up for us the practice that we have and what it is that we do and how it makes a difference, and provide us with information and hypotheses for further studies that would fit into this hierarchy of evidence at a higher level. We know already that our chaplains and chaplain colleagues are using some of the books that we have put together of case studies for their own education. There's nothing like reading it and seeing how someone else does it and then talking about it to, again, help inform and have it wash over you as you're doing your own practice. Sarah said that we would demystify this process, and I think that probably it doesn't need much demystifying. The fact is that we are narrative people, we write stories, we write verbatims. Writing case studies is not that foreign to many of us. So it's also a great entry point for people who might be research hesitant. And then finally, and I am going to talk a bit about this, more of this today than I have in previous opportunities, we need a large number of case studies, because what we want to start doing is what our colleagues in the social sciences have done, which is to analyze them up against one another, to look for patterns and themes, to develop theories, to develop hypotheses that then can be tested through both qualitative and quantitative methods. Next slide, please. We posted for you here the three books, the first three that are actually collections of case studies in our profession. As you know, there was also an edition of the Journal of Healthcare Chaplaincy way back when that featured several case studies as well as responses from colleagues, both chaplain colleagues and non-chaplain colleagues. So the Fichet-Nolan volumes, the volume that I did with my colleague, Karen Puglisi, again, are available to you to take a look to see what is it like to do case studies. What does this entail? What is a case study? The last one is a fascinating volume that, again, I commend to you by our colleagues in the Netherlands, that looks not only at case studies, but begins to talk directly about what it is that they contribute to our profession, to our learning, and to research. So again, I highly commend that to you, and I'll reference a couple of articles that appear in that volume in a few minutes. Next slide, please. If you decide after today's webinar that you want to begin to explore doing case studies, and we hope some of you will, then I would like to encourage, especially this group, to think about doing a collective group of case studies. There's a lot to be said right now in our discipline. We've got a bunch of different case studies all over the place. Our book is perhaps the exception, that it had a theme to it. It is time to start to see what is it that we can learn if we intentionally design programs for case studies that will help us gain insight into various aspects of what we are doing. So in the right-hand picture here, comparing multiple case studies of military chaplaincy, this article is one of the chapters in the book, actually, from our Dutch colleagues. And they did exactly this. They sat down and they decided that together they were going to design case studies, try to cover the field of military chaplaincy in all of its various aspects. And then, to our benefit, they actually talked about what did that process look like of doing multiple case study research and using an intentional design. On the left-hand side, you see the algorithm, which again suggests that there is a way to begin slow, have a couple of case studies, figure out what we need, start comparing them, build on those, an iterative process that hopefully yields this very rich outcome that could include not just individual case studies that stand on their own as important sources of knowledge, but that generate theory and that again may have even policy implications. And I know in the area of elder care, that's probably quite important. Next slide, please. So in thinking about methodology for multiple case study research, there's lots of questions you all should be asking yourselves, in my opinion. How many do we need? Why 3 instead of 10? Are these cases representative, paradigmatic, outliers? Do we have a critical case in here? I would suggest purposive sampling, again, selecting cases that are relevant to the conceptual framework or the research question at hand. If this is a communal project, which I think is the great approach these days, what is missing based upon the expert knowledge of this group? Do we need to invite other people in? Who decides, right, reflexivity of this process? Who decides what's going to be included when we publish these? Have we included the perspective of various actors? Have we paid attention to issues of power and inequality as even we've collected these case studies? So again, a very intentional process of coming together to decide what is it that your area, right, in geriatrics, long-term care, elder care, what would it benefit from? Do we need a set of cases that might compare to how other chaplains in non-geriatric, non-long-term care areas compare? What would be helpful? Very intentional. Next slide, please. I thought I'd share briefly with you there you go, the process of our book. It fits somewhere between the intentional multiple case studies and just convenient sampling. So when we decided we were going to do this project, we had already done a study, a survey of chaplains looking at their contributions to medical decision making. The second phase of that study was doing interviews with chaplains. We had hoped we would also be able to publish case studies, but as a result of those first stages, we had already generated some, I call them domains, where we wanted to know more. We wanted to delve deep into them. And you see 3 of those lifted up here. The chaplain in some way contributes to medical decision-making by paying attention to the patient as person. The chaplain also helps negotiate strong emotions that keep family members and patients from being able to make decisions or conflict within the family. And then understandably, the chaplain contributes to bridging religious and cultural differences in the process of decision-making. So we had a focus for the volume, and then we had these domains that had arisen from the research. And we sent out a, come, give us your case studies in this area invitation, which is more of the, again, you know, let's just see what comes in, might make a good case study, who can write, analyze that. And fortunately, we were able to have 3 substantive, really strong cases for each of these domains. We did not find case studies that spoke to other domains that we had not identified in our research. Otherwise, we might have redesigned this collection and this multiple case study book. Next slide, please. We solicited multiple cases around a singular theme or way in which chaplains, an aspect of chaplains' role, because we wanted to be able to step back and do some analysis of all of these case studies. If you have taken a look at our book, you'll see that it is divided into 3 sections. So each case fits under one of those 3 domains. Each case then has 2 respondents, a psychologist, a palliative care physician, again, analyzing the case in addition to the reflection that the chaplain has provided. But those kind of stay within their domains, right? What we wanted to be able to do is put all of these case studies up alongside one another and ask some other questions. And so, in fact, we have done that. And I presented on several of these themes or these patterns that came out at some conferences. One of the things we really wanted to look at was the role of the chaplain on the medical team. And so again, by having these case studies side by side, doing some qualitative analysis of the content, we were able to lift up the content that you see here. And on the next slide, please. that again talks about what is it that make chaplains effective contributors to interdisciplinary professional shared decision making and to contributing on the medical team. And when you have that many case studies side by side, you can also say, what's absent from these? Why is it that these folks succeeded and whereas some others have not been able to contribute in this area meaningfully? So just a quick example of multiple case study analysis. Next slide, please. You've also hopefully seen this lovely article by Steve Nolan, which appears in the volume, the fourth volume that I mentioned earlier, on theory building, right? Using cross-case analysis to build theories within chaplains, building toward a theory of chaplaincy care. So Steve Nolan, our colleague, did exactly what I'm talking about with many of the case studies that are out there. He brought a lens with a theoretical framework to the case studies, looked at them, and then came back and modified his theory based upon what he found in those case studies. And he was able to identify components of a theory for chaplaincy care. And you can see again the content of that. I don't need to read that for you. But that's the other incredible benefit of having collections of case studies. Let me just say, there's a lot out there right now. If you want to do more of this kind of work that Steve has done, rather than writing your own case study, go for it. I'd love to see people do more of that. Next slide, please. So let's talk a little bit now about the nuts and bolts and how to do case studies. Oh, let me stop. Let me mention one more thing. I really need to lift up that there is a new volume that will be coming out soon on pediatric case studies that follows some of the suggestions of the multiple case study intentional design and methodology and analysis that I've just presented. And Kate, my colleague, Desjardins, is one of the editors for that volume. Some of you on the line, probably not pediatrics is way at this end versus elder care, but you never know. You might know a colleague who's working and contributing to that volume. So let's talk now about nuts and bolts. Next slide, please. So this is thinking, okay, you guys are going to dive in. You're motivated after today. You know how important this is. What is this going to look like? Well, there's a lot of different types of case studies. And again, I've just taken from the research literature on case study methodology and given you a taxonomy for them. I think mostly in our profession, we have written intrinsic case studies or descriptive case studies, where these case studies are meant to stand as a whole, right? They tell us something. They may not be generalizable, right? We're just trying to gain insight into this phenomenon of a chaplain providing care to this patient with cancer in the outpatient cancer setting, right? I would say many of the case studies in our book tend to be slightly more instrumental. We were asking our participants to actually explore, right, a theory or question, to use a single case to, again, kind of shed light on the phenomenon of how do chaplains support medical decision-making? What's involved in that? Our colleagues in the social sciences do a lot of what I'm going to call explorative or explanatory causal case studies. So one quick example, somebody writes a case study observing a classroom of teaching for autistic children, right? That case study is then embedded in this whole body of literature on pedagogical methods for teaching. What's unique about the developmental and learning needs of children with autism? How does that case fit with that? So again, begins to open up the question beyond just that case study, and then possibly refers to other case studies. Next slide, please. Okay, hopefully you're ready to get started. Some of you may be thinking, oh, I've got a great case, or wow, I better keep my eyes open for one. Well, those are exactly what I would encourage you to do. Think just like that. This is not that hard. It takes time, it takes intentionality, it takes partnering with colleagues who understand the rigor of case methodology, but you're the person who is the hands-on person involved in the care and can, again, collect those stories and bring them back with the help of your more experienced research colleagues and begin to develop them into data, right, into data for what we know about what chaplains do. Your case does not have to be extraordinary. And in fact, maybe we don't want extraordinary cases to start. Maybe we want to cast a light on what is the usual care provided by chaplains in this setting for elders, or in a nursing facility, a long-term care facility. What we do want to be sure that these cases are about is that it's about the profession of chaplaincy. It's not just a case where you're observing the music therapist leading, you know, groups of elders in their setting week after week. That's a different kind of case study. We're looking for ones that really advance our cause, as it were, advance what we know about our profession. Because of the narrative nature and the unfolding nature of case studies, you can actually see better than almost anywhere else how our assessments of what's going on, the interventions we lead to our interventions, and then actually hopefully result in some outcomes that we can name. And historically, case studies within chaplaincy have spent some time attending to those that affect cause and effect, right? How those tie together. And that's part of the job of the chaplain writing the case study, is to step back and say, here's why I use this. Here's what it's led to. Here's why I decided to do X instead of Y. Here's why I observed. Oh, maybe the next time I would use a different intervention. That's what it's the opportunity to do. When you start getting ready to read case studies, or to write your own case study, I cannot emphasize enough the importance of reading other case studies to get some sense of what we're looking for. And then ask yourself the question, what was a case I've worked on recently that just has so much richness in it? I think it just sheds light on this important aspect of what I do, right? What made it this way? Why did I do what I did in this scenario, right? That's one way to look at a recent case you've had. Too far back, if the case is too far back, honestly, many of the details are going to be lost, and it's going to be hard to negotiate some of the ethics of the case, which I'll talk about in a moment. You can also do what our colleagues, again, in the Netherlands have done. They have groups of people meeting, and they support one another, and they select cases together as these cases are coming up in their practice. So keep an eye out, right? So you know you want to write a case study about, I don't know, a person with dementia and how you were able to reach her through a modality of spiritual care. But you don't have one already. Well, you're going to be doing this work for the next few months, next 6 months, year. Keep an eye out for a case then, and that will give you the opportunity to do what I think really helps in the construction of a case study, is to keep track in kind of a journal form of all of the meta messages, all of the observations you have about what's happening. Pay more attention with more intentionality to why you're doing what you're doing and what is going on, so that you can bring that to this critical reflection on the case study. Next slide, please. So our colleagues, George Fachet, Steve Nolan, have provided us with what I'm going to call a general template that we seem to have adopted so far in our profession for case studies. And again, if you read case studies I've suggested, you'll see that most of them follow this approach. Looking at the context for the case, that includes some kind of self-revelation about your location, your bias, your experience, why you chose this case, a little bit of your biographical information. The heart of it, right? What is the case study narrative? It may include some actual verbatim sections of the interactions. This is not a verbatim. Let me be clear, a case study is not a verbatim, but it is helpful sometimes to illuminate really kind of pivotal points in your care using actual verbatim conversation or excerpts, right? And then what we all must do to make this case study more than just a report, right, is some kind of critical reflection. And that can be, as I mentioned before, looking at the interconnection between assessment, interventions, and outcomes. It can be paying attention to the conceptual frameworks that actually informed the care that was being given. That's what we had our case study writers do, is to look at how narrative medicine informed their practice, how theories of grief, family systems literature, again, played a role in the care that they gave. Or if you're providing case study in a particular area of chaplaincy care or interprofessional team dynamics or on a theme, right? Let's critically reflect on how this case contributes to those outcomes that we're looking for, to those analytical frameworks, and how it might build then for us, as I said before, some of the knowledge we need to say more about how it is that chaplains contribute to medical decision-making for patients with serious illness. Next slide, please. Last, but probably most importantly, are the ethics of case study research. And you saw in the introduction that I now mostly do full-time ethics. I was a healthcare chaplain for 30 years, lest you think I come without qualifications. Did oncology care, which is where I met Bob, the person who I wrote about in our case study book. I was very fortunate in that Bob, although he passed away, I was involved in his family, with his family and in their bereavement. I actually did Bob's funeral, right? So I knew them quite well. When I decided I wanted to write Bob's case, or write Bob's story, make it into a case study, I was able to do what has quickly become the kind of emerging consensus ideal practice, if we can do it for our profession, which is getting the permission of the family or the patient to publish their case study. That had the benefit for me in that I did not have to disguise a lot of the information in the case study, not even my own location, which was fabulous. I had the added benefit in that one of the daughters of Bob was actually an editor, and so she took it upon herself to edit the case study. You're probably not going to get that. But again, what we're seeking in the ethics of case study research is a balance between preserving the richness of your encounter, the chaplain encounter with the patient and family, and protecting patient and family privacy, right? The challenge is that for us, many of the richness is in those details, right? So how do we, if we can't get permission or the patient and family want it published, give us permission, but don't want there to be any chance that someone might recognize them, how do we change those details enough? So what we know in the literature is that there are two methods. One is removing, limiting, or altering identifiers, ones that are listed here. The other is actually adding in extraneous material, building a composite of two or more cases, right? So it can be slightly more of a representative case than an actual single case. So whichever method you use, the final step in this should be also having your colleagues in your, let's say, the group that you're working with, to read them and review again for privacy protection, among other ethical issues that may be involved. I think that's all I'll say about ethics. There's other layers, but that's not the whole point of our time together today. And I think with that, I will turn it back to my colleagues to talk more about how do we take all of this and bring it home to the work that you're doing, the care, again, demographics, location where you all work, so that you can get us what we need, some insight into elder care and chaplaincy.
Thank you so much, Jeannie. That was fantastic. Every time I hear you speak, I get something new out of this whole process and get a deeper understanding of why it's so critical to be doing case study and how to be doing case study and recognizing the variety of case study options that we have before us. I'm about to go through 3 slides. I'm going to begin by defining the setting for case studies in long-term care and to identify a couple ways that we can approach it, just to highlight a couple of those ways. So when we define the setting to complete case studies in long-term care, we recognize that there's really no systematic naming in the United States. Some naming is dependent on state regulations. So we propose taking a broad perspective on the settings and identifying everything from skilled nursing homes, which often includes both residential and non-residential care, palliative care, and hospice care, In addition, possible settings include memory care, assisted living, independent living, senior housing, and adult daycare, which typically provides services to older adults who are living in some kind of dementia state or other cognitive declines that make it difficult for them to be home alone during the day. Next slide. As Jeanne talked about, the importance of intentional design is key in order to meet certain needs and or to fill certain gaps in chaplaincy. And I'd like to expand beyond chaplaincy to talk about case studies in terms of interdisciplinary care, because I'm trained in both social work and chaplaincy. So we want to highlight two primary ways to develop case studies in long-term care, either by focusing on the various modalities / types of spiritual care in long-term care, or by focusing on some unique service line in long-term care. So we're going to take each of these one at a time to give us a feel for what they are and how they might be useful to us as we consider how to develop case studies in elder care. Next slide, please. When we outline modalities of spiritual care in long-term care, we see a variety of creative narrative approaches, including dignity therapy, life review, and reminiscence. To get us all on the same page, let me provide a brief summary of each. Dignity therapy is typically a brief intervention for people with terminal illness that centers on meaning making and purpose with the goal of reducing distress prior to death. It often involves psychotherapy techniques to address illness-related concerns. Sometimes sessions are recorded to serve as a legacy document for loved ones after the person dies. Life review and reminiscence are similar to dignity therapy in their focus on meaning making. The differences are that these two approaches are for older adults regardless of medical diagnosis, and they incorporate the process of reflecting on the past, and it can be both positive and negative parts of a person's past. Erik Erikson, who is famous for developing 8 stages of psychosocial development, used life review as a way to help adults address and possibly resolve regret and conflict. And he reported that the process reduced stress, increased self-esteem, and provided a kind of holistic satisfaction with life. Art and music therapy are often group interventions, but can also be used to achieve individual goals. For instance, music therapy can involve listening to, creating, dancing to, moving to, singing to music. And similarly, art therapy is a form of self-expression as well, through painting, drawing, even modeling, each with different therapeutic aims. What makes care in a nursing home / long-term care center different than in hospitals? All of these approaches work well in long-term care settings in terms of providing opportunities for both group involvement and one-on-one care that enable long-term building of rapport, relationship building, and consistency of care over time. Next slide. Turn it over.
Thank you, Kathy, very much. I appreciate that. So Kathy mentioned that we're going to be looking both at modalities of care and also unique service lines within elder care, within the continuum of care that we provide service for. And when I think about that, it comes to unique service lines that we have, and we end up covering frequently a lot of those service lines, as opposed to in our acute care colleagues who, focus on being a pediatric chaplain or an oncology chaplain. In our setting, often we cover all of those. But then there are some unique ones specifically for long-term care where I think we have an opportunity to fill a gap and talk about what it is that we do. One of the biggest areas is memory care. There is just very little out there, especially in the way of case studies, that talks about what it is we do in the memory care setting, what it is we do for our residents with mild, mid-stage, late-stage dementia. So that is perhaps a service line or a unique opportunity we have to discuss case studies. Second one is, of course, short stay rehabilitation. These are the patients who come to us with perhaps a life-changing event, such as a stroke. They're with us for a short period of time. We assist them to return home with a completely different life. That's a unique opportunity we have to generate some case studies and show what it is, what services we provide. The other thing about some of our maybe not service lines, but opportunities that are available for us to generate case studies include some of the things that are unique about the work that we do. For example, our group work in dementia care, our worship services. Now, while there are worship services in other settings, in the skilled setting or in the elder care setting, those worship services are something that chaplains do on a regular basis. And then there's a whole realm of what it is we do when we do a worship service on a dementia unit versus what it is when we do a worship service with our healthy aging population, either in the community or in assisted living or independent living. Very unique opportunity. One of the things that we also have a unique opportunity with, which our colleagues do as well, but when working with family members, sometimes we develop relationships with family members that last decades, where we live alongside them as their mother or spouse ages. Those are opportunities that we have to reflect the care that we do over a very long period of time. I'm just fascinated by the opportunity to explore how do we write case studies that span the decades, and what do they bring to the work that we do as chaplains? What would the study of that bring to how chaplains care for folks? So we have modalities of care, we have unique service lines, or things that make the care we give unique. So if you'll indulge me, what I'd like to do, next slide, please, is to share a little bit of a case study that I have written. And for those of you who are new to this was my first attempt at writing a case study after doing a lot of the things that Jeanne has recommended to us. One of the things that struck me and why I wanted to write this case study was, as Jeanne mentioned, the richness that was involved in it. So to tell you a little bit about this, first starting with the context of the case. So the case takes place in the common area of a large memory care unit in a large skilled nursing facility. There are 50 residents on this unit, and their cognition is evaluated using the MoCA scale for cognition. And the folks on this unit typically are moderate to severe on the MoCA scale. Now, this turned out to be a group, so there were ultimately 7 residents who were involved in this group discussion, but there were 2 residents that really gave it the foundation, and it was this initial conversation between these 2 residents that kind of created the group atmosphere. The first resident was an 81-year-old white woman with Lewy body dementia. The second was also 81 years old, also white. She had anxiety disorder and moderate cognitive impairment, really of unknown etiology. The group occurred spontaneously in response to the chaplain's observation of increasing emotional distress within the common area. Other care staff, this occurred in the early morning hours, other care staff, as we know, in the early morning hours are typically engaged in their busy care for the physical needs of the resident. Not that we don't all care for body, mind, and spirit, but their goal is to bathe and dress and support people in dining during that early morning time. So that's the setting in which this occurred. Next slide, please. The chaplain had been hosting a weekly spiritual reminiscent group on the memory care unit, and the two key residents were familiar to the chaplain because of that group. After spending several minutes observing the general milieu before intervening, Chaplain noticed that the resident with anxiety and the cognitive impairment of unknown etiology was engaged in very loud behavior, yelling for the staff, asking the staff to help her find her daughter. She was frustrated, she was loud, she was angry. And the impact of that really was decreasing the overall or increasing the overall dis-ease in the common area. Chaplain made the decision to bring these two residents that she knew well together and focused on the topic that resident number one, the one who was yelling, focused on the topic that was bringing her anxiety, preparing a meal for which she needed support from her daughter and her inability to locate her daughter. As the conversation between these two residents took hold, and it took hold primarily by focusing on the topic that the resident who was yelling was focused on, preparing a meal. Something very spiritual when we think about the women that we care for and their meal preparation and family gatherings. So the chaplain brought these two residents together, was the catalyst in helping them continue this conversation about mealtime and being with family, creating kind of a coffee clutch, building relationship between the two of them in the moment, and then began observing the rest of the unit and how the dis-ease had rippled through those folks who were in the common area. Next slide, please. As a function of observing the remaining area and having just two people talk, the chaplain made the decision to slowly bring others into the conversation about mealtime and family and the sacredness of that, until the group was 7 and spoke together about those things for a very long period of time until the afternoon meal. So this case study, which I wrote in giving critical reflection to it, had me asking two questions. Can we call hosting a coffee clutch on the memory care unit spiritual care? Is that what chaplains do? Is that spiritual care? The second question for me was, how does offering this type of spiritual care during the busy physical care hours support our IDT and at the same time improve resident well-being? So the things that I was focused on while I was providing care was building relationships first and foremost. When in the memory care unit, relationships are in the moment relationships, as we all know. Relationships have been identified by our Australian colleague, Elizabeth McKinley, as critical to spiritual care and aging. So my first goal was really to build relationships that may serve to offset the relationship that was missing in the time. Where is my daughter? The second thing that I was focusing on was being the catalyst for those relationships. So as resident number 1 began to decline in her intense anxiety and loud, frustrated behavior, and the conversation grew between those two, A relationship was established, and others were able to enter the group with careful introductions and intentional thought about who to bring into the group and how. And the last thing that I was focused on was grew out of some research that was done in geropsychiatry hospital units about the importance of staff sharing not only place, but moment with the residents or the patients in their case. The study found that when staff are able to share both place and moment, that it improves the well-being of the residents. My IDT members were busy doing other things, and while they were able to share some moments or some place with folks as they came by, they weren't able to be focused on the residents in that unit. So what I was able to do is spend both place and a moment with the residents, decreasing the overall disease in the common area of the memory care unit. So that was my first attempt at reflecting on something that had happened that many of you may be thinking is frequently common in what we do, but to actually think about it in terms of writing it down as a case study. How do you write a case study that is a group interaction? So I would be really curious to put Jeanne on the spot and get some feedback for her about this case study, but more than anything, next slide, please. I am hoping, Kathy and I are hoping that what we've done in our brief webinar this afternoon is to whet your appetite for case studies in geriatrics and long-term care. And then we'd just like to engage in a little bit of a conversation. So please, please add your questions to the questions box that you see there so that we can answer any questions that you might have. And thank you very much. Kathy, have we had any questions come into the question box?
I don't see any.
I guess as people are contemplating, trying not to feel overwhelmed. I want to say, Sarah, your case was really lovely, really interesting. I mean, for me, it highlighted something that is so different from what we normally think about as chaplains in the inpatient setting, for example, acute care setting doing, let alone even just the questions you brought to it were really interesting. So I appreciate that we can bring our own questions to case studies, right? It's almost like you had an opportunity. It's a what I'm gonna call like an iterative process. You're kind of letting the case speak for itself, but you're also bringing a lens to it to explore it. That's, I think, part of what we were trying to do as well. But I just want to appreciate you guys. I think there's so many opportunities. It would not take much to get a group of people together and publish a really rich collection of essays, and we would all benefit from that. Many of us know so little about what you do.
Thank you, Jeanne. Thank you for that comment. It was interesting to try and pose those questions. You know, I often feel like I have to search for what it is that is specifically the chaplaincy piece, and thinking about the spiritual nature of engaging in conversations around preparing meals for family and just cooking. And some of the dialogue from the group was just tender and beautiful. So yeah, it is a different lens. It is a much different view, I think, than our acute care colleagues see.
So we have had a couple questions come in. So I'm going to begin with this one. How do we know when to add things like race and gender to a study?
My first comment is if they matter to what you're looking at, right? So I think about, let's say I'm looking at a case study that examines racial discordant care between the chaplain and the patient. I obviously am going to need to identify my location and that of the patient, right? Because that's the question under examination. I would also just think that if in your own analysis, maybe it's racial concordance, or maybe you just somehow know that your location has made a difference in how the interactions play out rather than just being a chaplain. I don't know quite how to get at that, but I would think in those cases you would want to name it. I guess the flip question, I don't know why you wouldn't want to. I mean, cases are about the richness, the contextualization, the location of all of us, right? The richness of the story. So that someone grew up in the South and loves fried food and misses that and is used to, I'm thinking of your case, Sarah, is used to a certain kind of, I don't know, afternoon tea or coffee clutch or going to the local, you know, whatever, general store on the weekends and meeting up with friends there, like where they have food together, right? Seems to me that that context is important. So naming pieces of it but naming why they're important. Why is it important for me to say, I am a white woman, blah, 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 and this patient was Latinx, right?
Yeah, exactly. As a part of building culturally competent care.
Yes.
Anything to add to that, Sarah, before I go to the next question?
No, but I really do appreciate the question because I've had the same question myself. And Jeannie saying that I think really helped me a lot, especially where it is part of what you're looking at, but also the why would you not? I appreciate that.
So the next question is, for whom would a case study be written?
Oh. So I suggested in the beginning that case studies serve several purposes. One is it contributes to, a body to data for our whole profession and, you know, medical care, but also they can be written for the purpose of learning, again, for teaching. So how do you train chaplains? How do you do education for non-chaplain members about what chaplains actually do? So interprofessional colleagues. So certainly contributes to I mean, one would hope that our colleagues care about what it is that we do and want to learn more about it so that we can provide better patient care and better interprofessional care, right? So I guess for that reason. And then to take it to the next level for those of us who want to do more research and take some of the patterns and hypotheses and models that are generated or theories that are generated in case studies to then test them out in the more quantitative methods of research. They could feed into those. Ultimately, our profession, right?
Yeah, is a preliminary building block to a different type of systemic data collection, to go from that narrative to more quantitative, perhaps.
Yep.
As a stepping stone, but in its own right, it has legitimacy and helps build the field.
Yep.
And I so appreciate, Jeannie, you saying, you know, to help educate our colleagues or to share with our colleagues what it is that we do. That's something that I hear frequently when we have network meetings, almost a lament of, I wish people understood what spiritual care was. I wish they really knew what we were doing when we host a group such as this or something else. So I think that interdisciplinary team sharing and support and understanding is just so critical. A lot of lack of understanding or just lack of knowledge, perhaps, in what each of us do that is different and how it meets the needs of the residents. So.
An interesting thought, as we're talking, you know, more and more we're thinking about community engaged research and bringing, not just doing member checking and, you know, making sure that we have the permission of patients and families, but one wonders if there might be some role for some of this for the communities that we serve. I don't know.
I love
Not
that.
really thought much about that in our practice yet.
Particularly as more participatory action / transformative approaches are invading research design methods, building research from the ground up, as they say, rather than from the top down.
Yep.
One of the things I did think about when writing that is how different members of the team might have approached the situation differently, so that I really could look at what is the chaplain's role in this moment, or what could be the chaplain's role. And I think that's an interesting question too. What different approaches do we employ, and what is potentially the different outcome of who and what? So, yeah.
That's why I love that Jeannie's book had, what, 2 respondents per case?
Yep.
To get that conversation going about looking at alternatives.
Yep.
So the next question is, are there any work study groups available and how do we find them?
Perfect. That's a plan.
Well, Kathy, why don't you take this one?
Well, so Sarah and I are co-conveners of Transforming Chaplaincy's Elder Care Research Network. And so we are looking for a way to start with some work study, with some work study groups, and then hopefully even building to publishing within that. So we actually also have some work study groups in areas of assessment. And so really trying to begin with people who are very interested and then see where we can go after we establish people who are really committed to the process. Sarah, what would you add to that?
I think that's a great introduction. We do want to get a work group together on geriatric and long-term care case studies with people who have passion around this idea. So absolutely. We'll show you in a minute how to reach out to us.
Yeah, we're ready for that. I think I got through the Q&A, and if we'll look at them again, but I don't see any additional questions. So if you want to move into next steps, that would be great in the couple minutes we have left. Perfect timing.
I do notice an error on this slide. It does still have the Chaplaincy Functions Network, but so instead of sign up for the Chaplaincy Functions Network, you would want to sign up for the Elder Care Research Network. The address will get you to the same place though, so please feel free to use that address. Same with the one below, you can reach us that way, or you are welcome to reach out to us directly via email or phone. So next slide. When you print the slide deck, you will have all of these wonderful references that Jeannie has provided for us. So, please feel free to access that. And Andy, Kathy, was there anything else you wanted to add?
No, but I do think Andy had some stuff on some upcoming.
Sure.
That would be nice to highlight.
We have a webinar coming up next Thursday with a great panel so that is filling up. And if you take the QR code, you can get right into the registration, or feel free to type in the URL. And then the week after that, patient religiosity and desire for chaplain services in outpatient primary care clinic. And both of these are being hosted by 2 former Templeton Transforming Chaplaincy fellows. If your appetite for research is whetted, we have our 101 course, which is starting up at the end of this month. And that is also beginning to fill up. Fantastic 5-week course. And if you've got more time to dedicate, we have summer camp. This year, we're going to be out on the West Coast in Los Angeles at Cedars-Sinai. So I encourage you to apply online, and you'll have more information there, also at the QR code and the URL, or you feel free to email me too if you'd like. And that is it.
Can you guys put your email addresses in the chat box if that's how you want people to get a hold of you, because they did not post. And you said they could contact you by email. So put those in so people know how to reach out.
Great idea.
Well, I am, for one, I'm looking forward. I won't put time pressure on you all, but I can read the pediatric case study book in the meantime, but then in the not too distant future, I can't wait to see what you're doing. And I just think as many of us in the profession, frankly, are aging, it'll also be really interesting to see when people asked about location, does your age matter, right? If you're a young chaplain providing care in a geriatric setting versus somebody who maybe people can identify with. Many of us will be benefiting from the work that you do, and hopefully not too close, but just in future.
Thank you so much, Jeannie.
Yeah,
Always a pleasure to work with you.
Yeah.
Thanks, everybody.
Andy. And thank you, Andy, for your help with this.
Well, this is always a privilege. Thanks so much.
Take care, everybody.
Thank you.